Coming to opioid withdrawal. So, opioid withdrawal is not life threatening at all. It is uncomfortable, it is painful, it is everything, but it's not life threatening. So, what happens is our body accustoms to all the fentanyl that the people are ingesting. There is down regulation of the receptor. So, when there is abrupt stoppage of opioid, we do not get time to relocation of the receptors to the above surface cell membrane, and the opioid withdrawal symptoms occur. There is down regulation of endogenous endorphin, dysendorphin, dynorphins, and opioid receptor occurs. An abrupt cessation will not allow time for the upregulation and increase neuronal firing, causing painful sensation and other. It starts 6 to 12 hours after the last use of short-acting opioid and 30 hours after the long-acting opioids. It can be abruptly precipitated by the naloxone or naltrexone or giving buprenorphine, which is the partial agonist antagonist buprenorphine. In fact, buprenorphine, based upon the patient profile, can actually produce symptoms of opioid agonist also and antagonist also. Opioid symptoms start like anxiety within the first one day, then in the next day there are pilorection, mydriasis, and the next day there are insomnia, muscle spasm, etc. Opioid withdrawal symptoms are very uncomfortable but are not life-threatening and rarely fatal. Vomiting and aspiration of the gastric contents causes pneumonitis and dehydration. Clinical scoring tools have been developed to assist the assessment of opioid withdrawal. The commonly used clinical opioid withdrawal scale calculates a score based upon the severity of 11 symptoms and can be used to assess appropriate dose for buprenorphine or methadone and to monitor response to treatment. What is the clinical opioid withdrawal scale? COWS scale. It tests pulse rate, sweating, restlessness, pupil size, bone or joint pain, runny nose or tearing, GI upset, tremor, yawning, anxiety, goose flesh skin. So 11 parameters are there: pulse, sweating, restless, pupil, bone pain, runny nose, GI upset, tremor, yawning, and goose flesh skin, and yawning, anxiety, and goose flesh skin. If the total score is 5 to 12, it is mild, 13 to 24 is moderate, 25 to 36 is moderately severe, more than 36 is severe withdrawal. Patients with mild opioid withdrawal are treated with symptomatic therapy, usually antiemetics and antidiarrheals as needed, and symptoms of moderate are treated with giving central alpha 2 agonist or clonidine. As we remembered, clonidine toxicity is a DD of opioid toxicity, na? Clonidine should not be used if the patient is hypotensive or bradycardic because it's an alpha 2 blocker. A test dose of 75 to 100 micrograms should be given before, and if there is no deep BP drop, we can give 150 microgram TDS of clonidine. Opioid replacement therapy with buprenorphine or methadone should be considered for moderately severe withdrawal. Buprenorphine और methadone. So mild है तो कुछ नहीं देना, सिर्फ फ्लूइड एंड ऑल. मॉडरेट है तो क्लोनिडीन देना है 150 mg TDS, और सीवियर है तो बुप्रेनॉर्फिन या मेथाडोन देना है. To treat withdrawal, standard doses of buprenorphine and methadone are started, titrated over next 2 to 3 days. We can give methadone 20 to 30 mg oral or 10 mg IM, and buprenorphine 0.3 to 1.2 mg IM or IV QID, or 2 to 4 mg sublingual. So 0.3 से 1.2 mg IV QID buprenorphine देना है. 1.2 mg IV QID buprenorphine to a opioid dependent person experiencing withdrawal. No methadone or buprenorphine should be given to an opioid dependent patient until the withdrawal symptoms appear. So don't just assume opioid withdrawal.